everyone. This is Susan and Erica again, and we are discussing part 2 of the client with pregnancy and pelvic girdle pain. In this particular episode, we're going to get into a bit more of interventions and some unique ways in which to really work with this population. Let us know what you think, and always thanks for listening. I'm Susan Clinton, and my co-host Erica Malo is here with me, and we're going to catch back up on my client that came to me with pelvic girdle pain and low back pain in her 35th week in pregnancy. How are you, Erica?
I'm good. Yes, it's. I'm actually looking forward to hearing the rest of the story here. You know, it's funny. I had I don't know who I was talking to recently about postpartum and women's health, and I just think it's really important to highlight this. So let's go. I'm ready.
All right. The last time we were talking, we actually made it into a little bit of intervention because one of the things that I was stressing was the idea that as soon as you see some faulty movement patterns or movement patterns that are painful, you know, I'm not so sure we want to call them faulty, but dominant movement patterns that they're doing, and they actually happen to be painful, I always like to stop right at that point and begin to work in those movement patterns to see if we can change them and see if I can give her some confidence to move with greater ease and less symptoms. And I think the last time we talked a lot about the bending over.
Yep.
And squatting and sit to stand. And I think we talked a little bit about, just changing, legs out, legs in, toes out, toes in, doing some different kinds of positions and things like that. And I got her to, bend over and squat a lot easier. And we actually threw things on the floor, so it was real time mimicking, picking things up, just like she would normally do, like her tennis shoe. You pick up your shoes to put them on, oftentimes. So we did some of that. And then we talked a little bit about sit to stand, which I thought last time, and I just wanted to re-highlight that again. I thought that was fascinating, because I took it to a different level for me. Instead of just looking at her hips and her knees and her, and just watching her whole body move, I stood in front of her and looked at her head like it was on a flag, like it was a flag on a flagpole, and really wanted to see, was she shooting off to one side a whole lot? And was she favoring something, or what was her movement choices that she was making? And indeed, she really was listing to one side. It almost looked like a sailboat listing over on its side with the wind. Coming through. And so so I just, kind of pointed that out to her, put my hand on the side of her head and said, just, try it again. And she could feel how much she was pulling into that. So she started to make some changes just based on her head movement, which I thought was fascinating.
Yeah.
For two reasons. Number one, you see so much more at the distal end than you do right in the middle.
Right.
Just kind of like the wake up, Susan, look at some different points of view and take a look at that. The other thing is that I think we touched on this last time too, is that pregnancy, especially in your third trimester, there's a high risk for fall. And part of it is an anterior-posterior sway, of which they're vulnerable, which is, I think, why they adopt a coronal plane, type gait, where they're like going side to side and, widen the stance and all of that kind of business, because that sagittal plane is a little bit vulnerable. And I began to wonder, if she's listing in order, because I think naturally the body just thinks, don't fall over on your face. Hard to say. So I actually had the opportunity to see her again before this podcast. So I got a chance to play with that just a little bit and put that theory to work. So she had changed the way she was sit to standing, and she's so much better. Oh my goodness, she came in laughing and
that's great.
And just, the life is good, and I'm strong, and my pain is so much better, and so many things. So we played around with the sit to stand and doing some stuff in forward and backward sway, as realizing that balance wise that was a vulnerability for pretty much all pregnant women.
Yeah.
And so I got her not just to lean to one side, but to lean forward and lean back and do some different things so that she felt that there wasn't any kind of situation she couldn't get out of, like out of the truck on one side, out of the truck on the other. There's a lot of times where we have to change the way we sit to stand and directional wise.
Yep.
So I wanted her to have a lot of variance in that.
Mm-hmm.
And the coolest thing was, by using the head position, we were able to change so much. And all I had to do was just every once in a while kind of just help her guide her head.
Yeah.
So, and her body would just respond. And it just reminds me so much of that neurological system of the
Right.
eyes lead the way. You
Yeah.
know, we're an anticipatory human that is supposed to be scanning our environment and
Mm-hmm.
doing these things. And we're not supposed to be living in the world of reaction. We're supposed to be
Mm-hmm.
living in the world of action.
Yep. Yep.
And by bringing, I think, that system back in, it starts to make me think about dizziness and pregnancy and
Yep.
postpartum dizziness, and that maybe because of the reaction to the whole change in our body, are we losing a little bit of that anticipatory system, and is our vestibular system beginning to lock down to keep
Yep.
us stable? And
Yep.
because of that, we're losing the variance in our eyes and the certain things that we, that make us so uniquely human. Is that system getting dampened a little bit at this point in time? So it was really a lot of fun to play with that system to
Yeah.
affect change in her body.
Yeah. No, it's great. It's interesting because, it's like this whole top-down approach, but you realize there's so much proprioception stored up there,
Mhm.
and one of the courses I was on, I think this was LJ Lee's course, and a while ago, and we talked about eyes and the relationship to the neck, and
Mhm.
she was saying, which makes a lot of sense, that she won't do or won't, like when you have an eye exam, you're in like that contraption, you're in this sort of forward head
Mhm.
posture, you're compressed in your CV joints, and the vision changes when you're out of that position. So why have an eye exam when you are sort of in this contraption, and it's going to be completely different when you're out of the contraption?
Mhm.
So the eyes are so important, and I think that was quite interesting. And I would also look to do more work in that area, especially with people who have these center of mass sway issues. So
Mhm.
I think that's great.
Yeah, I think what is the I would have to look up the reference on this, but 50% of the proprioceptors in the body is stored in the suboccipital region.
Oh,
So,
interesting. I didn't
wow,
know
how
that.
important is our head in those CV joints, right?
Mm-hmm. Mm-hmm.
It's a matter of we have to know where our head is in space. We have to,
Yep.
and our eyes are a huge driver of that, and they're actually connected all the way through the trigeminal system, into the cervical, nucleus of the trigeminal system, and all of those connections into the cerebellum and into the vestibular system are just hugely important, and such an easy area to tap into on people who don't have central nervous system issues per se. In other words, they haven't had a stroke, they haven't had a brain bleed, they don't have a
Yep.
tumor in there, things like that. But you can tap into that system and begin to change it, and it certainly changes, how the whole periphery responds,
Yep.
via the cerebellar system and that whole matching back and forth.
Yep.
But I find it fascinating with pregnancy because the changes are happening so fast in the peripheral system that the central nervous system has to adapt and change rather quickly, and it's going to try to be as efficient as possible. So it may go into that don't move out of this position kind of thing, you're safe here. And as soon as we start locking our vestibular system, we start getting that kind of fixated eye thing,
Mm-hmm. Mm-hmm.
where the eyes start to lock and stare straight ahead. You get that with people who are dizzy. They tend to like lock onto an object and hold it because it helps them kind of sort out the rest of their environment.
Mm-hmm.
So that they don't have that rapid eye movement and those other things that are going on that's distorting their visual field.
Yep.
So anyway, I played around with that and used that with her in the upright postures, and we had a lot of fun with it, and we were able to go up back into standing and movement. She'd already done some forward and backward sway and side to side sway, so we took it into moving around in circles and stepping around in circles and variants of steps and walking backwards, and turn some music on for a little bit of dancing, and just movement to kind of see what would come up and what she could express in her movement system. And my cues to her were changing her eyes. Look over here as you do that, look here, look there, kind of
That's
see if you
great.
can, think about looking around as you make a turn, and just kind of starting to just enrich that system just a little bit. So that was a lot of fun. And that was a progression that I used for her upright stuff, which was, good for her, to encourage her to just automate that deep muscle system, the postural control muscles, her multifidus, her deeper abdominal muscles, her pelvic floor.
Yep.
And we can access all of that through voice. So, singing is kind of a fun way to do it.
Mm-hmm.
and get that happening. But let me just take you back again to the first day when I saw her and some of the interventions that I went past, because we talked about sit to stand, squatting, upright, moving, bending over. But one of the things that we also did was, I looked back at the pelvic girdle pain questionnaire, because as we talked about last time, it gives you so many clues as to the activities that are really difficult.
Yeah.
And 9 times out of 10, and the literature supports this, is that moving in bed is just one of the hardest things that they have to do, handling and dealing with the bed situation. And I think part of that is because of tissue creep.
Yeah.
Tends to be a little bit probably more prevalent in pregnancy, due to some of the tissue changes.
Yep.
And then of course the sensitization of the joints.
Yeah.
And with her, it was her pelvic, it was her SI joints, her pubic symphysis, her low back, had just been highly sensitized since December when she was having all of the pain, and this is now June. So there was a little corkscrew in the works as we started to talk about the bed and moving, and she said, well, one thing you need to understand is we have a Tempur-Pedic mattress. My first thought, the old me was like, get rid of it. I'm thinking, what a horror story.
Yeah,
a Tempur-Pedic mattress that holds you in place and you have tissue creep, you're really going to be a turtle on your back. You're not going to be able to move.
Right.
In reality, you can't do that.
Right.
Let's try to figure out if we can make it work around this Tempur-Pedic mattress. So one of the things I did was I just said, show me how you lay down. Just show me. And, she did. She showed that I wanted to see what movement, pattern, was expressed. And she, kind of sat on the edge of the I have a high-low table so we could put it to the level of her bed. And I told her which side of the bed, let's do it just like you do it at home. I just really want to see what happens. And she grabs the bed and picks her feet up and leans back and lowers herself down. Not a bad movement pattern, but it gave her a lot of symptoms.
Yeah.
So, and here I am. It's like, I'm not going to judge and say, oh, never get in bed that way, because perhaps she's going to be able to.
Right.
But it was like, let's change that.
Right.
And see how we can make this a little bit different.
She grabbed the mattress, you mean, in the bed so she pushed off from the mattress.
Yeah.
Wow.
So she
Got it.
She had to hike herself up onto the bed, and then when she was there, she kind of just did the whole jackknife backwards down onto the bed.
Got it.
And again, I said, it's not a bad movement pattern. It's just but it doesn't feel good when you do it that way. So let's do it a different way.
Yep.
And see if we can make that work.
Yeah.
So, so what I had her do was, just right back to the old log rolling, but I wanted her to just kind of feel that she had control. And a lot of people who work with people with pelvic girdle pain tend to tell them to put their knees together and lock them together. That tends to fire up the adductor muscles, which I think that they're already firing kind of wonky if you've got pubic symphysis pain. So I'm not so sure that you can get those things to fire together really nicely. And oftentimes I think even pinching that pubic symphysis could be a little bit problematic. So one of the things that I like to do is I like to do either two things. Number one, put your feet together and press your feet together. And not your knees. Concentrate on your feet so their knees are apart a little bit. Tends to fire up their hip external rotators.
Right.
And one of those being the obturator internus, which is a huge, broad, flat muscle on the inside of the pelvis.
Yep.
That is in a great position to kind of actually haul that pelvis around.
Yep.
The other thing you can do is you can take a strap or some TheraBand and tie it around the knees and have them do a little gentle pressure with their knees if they can't get the feet together thing.
Yeah, I love that.
So with her, I did both. And, I just said, kind of keep this like this and move yourself around and see if that changes anything. And, move around and see how that feels, maintaining this position. So she was able to lay over onto her side, get her feet up onto the bed, move around. That felt better. Then, of course, we added some breathing to it so she wouldn't hold her breath. Did some of the, a little bit of forced exhalation to that is up to the task. In other words, I don't want them to blow really hard with a lot of forced expiration unless it's a really tough task. I wanted it to just be, up to the level of the task. dependent on the task. And so we did a little bit of that. That made the whole thing easier so she could get onto her side. From there, we had to kind of start problem solving about how to roll over to the other side, some different things in positioning in the bed, and using kind of the same idea behind it. I just kept the TheraBand there for a little bit of training purposes so that she could, kind of had something to kind of think about, a little bit different than if I move my back will hurt. More like, okay, what am I doing here with my legs?
I love that.
That whole
Great
shift
idea.
of thinking there.
Great idea.
We got her, to where she could move and change positions. It wasn't, it dropped her symptoms about 70%. To me, awesome. That is like a fantastic
That's a win-win.
Thing. Oh, yeah. I just love it, And I never made any remarks about how your pain would go completely away. She's had it since December. It's going to be something she's going to need to work with. But I also didn't want her to just shove through it either. I wanted her to know that she could change her symptoms in a positive way.
Yeah, that's awesome. I love the TheraBand. It's a great idea.
Yeah. So then we talked as she was kind of laying there. We got her positioned and talked about some other things she hadn't thought about. A nice flat towel up underneath her belly on her side so that, her baby was lifted up a little bit, just kind of kept the shift of pulling on her and on her trunk, and that felt better. She liked that. So she could play around with some different things and get herself in some different positions that were a little bit more comfortable, which because you want rest. Rest is really important. So we did that. And then one of the things I asked her is I said, how likely are you to use something like this band at home? I wanted to, and I said, and I want you to be super honest with me. Because I didn't want to set her up for failure. Take this band, wrap it around your legs, just leave it on when you go to sleep at night because it's rubber. It doesn't, well, it's not rubber, but we all know what a TheraBand feels like. Who's really likely to put that around their legs at nighttime?
Yeah.
And she said, I'm wondering if I can do this without the TheraBand. I said, fair enough.
Yep.
So we took the TheraBand off. We still had to get up off the bed.
Yep.
So she was able to, just because she got the feel of it with the TheraBand, she was able to actually, change her movement patterns and get out of bed without having the same symptoms. So, here we are. We've got a very strong, resilient young woman who her biggest hang up is pain. And once she learned that she could begin to change it, she took over, we wish they could all work this way. She was so empowered to take over and change that she figured it out herself. And she just wanted to try, and she wanted my facilitation and input.
Yeah.
So as we got to sitting up on the side of the bed, she goes, here's where I run into my problem. As she goes, she was laying on her side. She goes, when I get up, there's a ridge in the bed, obviously, that I have to overcome to get out because she's got this Tempur-Pedic mattress. And so I said, okay, let's just, if the ridge is there, the ridge is there. We're not going to change it, but let's change how you're moving. So I had her just rise straight up out of a sideline position, the old log roll down, log roll up kind of thing. And, and got her to understand that, okay, so you don't have to push against the ridge and do this. Just rise straight up out of it and swing your legs over. And so I said, now you're going to be sitting with your thighs up because you're on the ridge. So let's figure out a couple of things. I said, one thing we know about the mattresses is that if you sit there for a minute or two with your thighs pressing on it, it's going to compress. So give your body a little chance to kind of take away part of that hill. And then she was able to I said, just figure it out. Change how you would push it because she had never sat in that position like that on the bed before. And I said, just play with it and see what happens. And here's the most interesting thing of all. They never tell anybody that they can shimmy their hips when they have pelvic girdle pain or pubic symphysis pain. I am here to tell you that she put her hands on the bed and moved herself off that bed one leg at a time, shimmying herself to the edge until she could get in a position to drop her feet down on the floor without a symptom.
That's awesome.
So that throws that whole thing out the window.
Alert. It's so amazing the belief systems that people have, and
imposed on them by us.
I know.
That would be something that, another therapist would say, oh no, you have to keep your knees and your feet and your hips completely still and move.
Yeah.
She would have never been able to get off the bed.
No, and that rigid thinking doesn't work anymore.
No.
It never did, basically, but it just certainly doesn't work now.
So anyway, I let her figure it out, and she sorted it out through, her central nervous system had to figure this out. Okay, we got to get up and over this ridge. We got to move this way. What can I do? And I need to, and so it was a different movement system, but she was problem solving, and it worked great. When she came back in the next time, she said the only time that she runs into a little bit of difficulty is if her feet get tangled up in the covers as she's rolling side to side. So she just has to kind of simply wake up a little bit, untangle her feet, and then she's able to kind of sort it out. She gets some symptoms, but they're not like scary anymore.
Yeah.
She doesn't groan and moan in bed,
Yeah.
Her husband thinks I'm a miracle worker.
Oh, that's great.
He's like, no, you go back and tell him you're the miracle worker.
I know. I think it's good when you get the buy-in, even from the husband, especially since he's a professional athlete too, and it's. I think that's important.
Well, and he sees his wife is not hurting all the time.
Yeah.
So we don't want him to see her as fragile either.
Right.
We want him to support her in the amazing things her body's doing, and we don't want all this fear. She's got so much fear when she came in that first day. It's like so nice to see her just really embracing, her pregnancy and really talking about labor and delivery in a much more positive way now than the day she came in. And, I'm sure her whole family feels better just because she's probably gone back and said, I'm good.
Yeah.
I can do this. This is, I'm learning to do this.
So on the breath work that you were doing with her, since she's pregnant, how did you work with that in terms of just the breathing?
So with everybody, I always look at their dominant breathing pattern when they're at quiet rest. And when we're dealing with pregnancy, it's not that she can't lay on her back. I don't tell people they can or can't. I just say it's preferable on your side. You're comfortable on your side, so let's work on your breathing on your side. So I just have her I have them get on their side, one hand on their chest, one hand on their belly, above, kind of under the diaphragm, or, even down on top of the baby if they want to. They can still feel their belly move. And I just ask them to even that out, and get a little bit of change there so that they've got a change in their dominant breathing pattern. Oftentimes they tend to breathe pretty high in their chest, so there's a lot of pump handle motion going, and sometimes some extra scalenes and accessory muscle breathing, mainly because it's, it depends on where the baby's sitting. If the baby's sitting right up underneath the diaphragm, it's going to be more difficult for that diaphragm to engage as well. So we just kind of work on some positioning to kind of open that area up a little bit. And then I have them spend some time working on the lower part of their chest, because that part's moving pretty good. And, just starting to get that bucket handle type of motion going side to side, because they can put one arm on their side, laying on their side, and they can actually begin to feel that, start to move. And I'll just, draw their attention to that. But with to have breathing help with movement, I use exhale. And this is, a lot of stuff that Julie Wiebe teaches also. But it's something I've been using for a long time. It all dates back to the very first time I heard Mary Mastery talk. If you can't breathe, you can't function. And her biggest thing was stop breath holding. And it's just been kind of an axiom that I've worked with, because knowing how primal breathing is, it's like we can tap into breathing. Boy, we could automate a lot of systems. So I just have them, just like do a little forced exhale by blowing out like through a straw or through puckered lips. I actually make them pucker their lips up and blow out, because it just helps the oral muscle, facial stuff. There's another whole issue with that with women's health. But I just get them to kind of, think about doing that and make it a purposeful exhale as they begin to move. It's just like with weightlifting. Exhale upon exertion, until you're lifting to 1 rep max, and then you've got to, take a breath in, start the exhale, hold it, and then do your max lift. When you're lifting heavy, you do have to do some breath holding. When you're moving in bed, you shouldn't have to hold your breath to move in bed.
Right.
But if you're hurting and you're struggling, there's probably a lot of breath holding going on. She did show that to me as she was moving around. The other thing that I like to do, and I do this with a lot of my chronic pain patients, is I'll have them talk, because oftentimes they can't pay attention to if they're holding their breath or not, but they can listen and hear their voice. So I'll have them have a conversation with me as they're moving, and I'll cue them into, did you hear how your voice changed as you rolled over, or as you sat up, or as you, did whatever? I want your voice to be able to stay even as you go through those movements. So they have, kind of their own biofeedback tool when they go home to work with. This young lady was just, she made incredible changes in one day that she just bought right into the system and just did it. So there's a sample of a very healthy, resilient, human that just happened to run into, a pretty good sensitization, with her back and her pelvic girdle pain, and then run into all the fears that were out there about, oh my God, your ligaments are so soft, your pelvis is, deforming, and it's happening early, and you're having, blah, blah, blah.
And you need a belt, et cetera, and all that.
Yeah. So it was, so she was, one that I didn't have to really do much more than encourage her to find a different way to do it, and give her a couple of things that she could focus on, like, the TheraBand, or the, where are your knees, where are your feet, those kinds of things. And that was enough to, help her change her neural pathways and move in a different way. And then she was good. And it, carried on to, the intervention as we move forward. So the final thing that I just to kind of catch everybody up on, where do I go from here? It gets into a little bit more of specialized physical therapy, but we're working on positions for labor and delivery. If all things go good and she doesn't end up on a fetal monitor, she's got the ability to move, during her laboring. And, hands and knees and sideline are by far some of the better positions to get into. And if she could labor and even deliver sideline, there's a lot of information out there that actually can be a pretty good position for perineal sparing, because the baby doesn't have to push out and up over the hill to come through. So, we're going to work on a little bit of that. But basically what we're doing now is some good old-fashioned exercise. What is it that what does she do during her day? How can we turn it into a little bit of an exercise program to just give her that, oomph? She hasn't done anything for a long time because her pain was holding her back. Now she's ready to go. She has a new home, furniture is coming. She wants to clean her house. She wants to do these things. And it's like, let's, be smart. Break it up. Try not to do everything all in one day. Call on your support system. Get people to help. What do you need to do when you have to stand and cook? What kinds of, positions can you change? What about if you're, cleaning your kitchen floor? So we worked on some, all fours and, movement and things like that, crawling, because you'd have to crawl to get things in and out from under the bed. Let's be real. We got to put shoes down in the floor of the closet. We've got to hang clothes up and do those things. So we played around with a lot of different positions and did some strengthening stuff, and all of those variety of positions and things to kind of give her a little bit more ways to move and to change and to feel like she was exercising as she was going through her day, which seemed to work with her timetable right now. She's not going to start at a gym a few weeks before she delivers a baby, and we're going to have plans to work with her, as soon as we can after her baby comes.
Yes, very important.
To give her that feeling of, let's bring it all back together again. You can do this, so that she feels strong and confident as she's raising a young child.
Yeah, no, I think that's awesome. I mean, the whole APTA's vision, if we bring it back, we are experts in movement, and the specificity of the movement training that you're giving her is what makes us, what is good physical therapy, and you're making it unique to her, not just doing willy-nilly squats in the gym or things that really aren't relevant for her and have no meaning for her, and she probably doesn't even care about.
Right.
So if you can integrate, as you so, beautifully have done, integrate her daily activities into an exercise plan with cueing and looking at different movement strategies. And at the end of the day, we are trying to give the brain new and novel input into new movement strategies, which is exactly what she needed. And I think this is awesome. I'm actually looking forward to hearing more about her.
When I see her at the end of the week, I'll definitely be doing another pelvic girdle pain questionnaire to see how it's all changed.
Of course, right. So you've seen her
for that information too.
Yes, you've seen her twice now, right?
I've seen her twice now. And, she has some specific things she wants to work on.
Yep.
She really wants to work on some, even though they're going to childbirth education classes, she really wants to work on, some of the ways to get stronger into these different positions for labor and delivery. Remember, I said in the very beginning, her biggest fear was, how am I going to go through labor and delivery if I'm in this kind of pain right now?
Right.
And so she's still, and I'm all in with her. This is important to her. This is where she wants to go. So let's do it.
Yeah.
So we're gonna work on some fun postures and changing strategies and different things that she can do so that she feels like she's got a good amount of variance to be able to take into the process with her. And she's understanding. I said, all of this is great, but also be open to the idea that things may progress really fast and you don't get to use any of them, or exactly. And sometimes they have to have you lay still for a while when they're checking things. So I said that's where that other the activities you and your husband are learning in childbirth classes are great. And I said, if you want to bring him with you, if he's your designated support system, let's make an appointment to bring him in as well, so that he feels like he knows that you're, so he knows the different things he can kind of coach you with.
Exactly.
In the moment.
Yeah, because she's not going to remember some, I'm sure.
No. I think sometimes they try and they want to, but that's why you have a coach with you.
Yeah.
To kind of remind you, like, okay, breathe, let's rub your back with some tennis balls. Let's, do the different thing. And again, those are just novel inputs, to the system, because that system is pretty automatic. It knows what to do.
Yeah.
And it's just kind of just coaching people to just kind of go with that, and hang in there until, you get ready for the big event. And then magically the brain just kind of goes, oh, we're so focused on the baby. And that's the way it should be. So that's where I'm headed with her.
Cool.
All right.
Awesome.
So I think that this is a good point to end part 2 of the Tough to Treat episode. And what do you do with a pregnant lady with kind of what we would have to consider after 6 months, chronic back pain and pelvic girdle pain? And I'm Susan Clinton, and my co-host
Erica Mello
will be signing off at this point, and we'll see you on the next podcast.
Bye, everybody.